In this segment, Dr. Garber will discuss and demonstrate an extraction and immediate implant for a maxillary posterior tooth.
This image and the underlying photograph are representative of a typical case we also often find ourselves in, invariably somewhere just before lunch. And we have to make a decision on just what to do with that fractured crown, the upper right second premolar. We're faced with so many options. We could erupt that tooth, force the orthodontic eruption, do a little crown lengthening, put a post and core in it, and restore it with a single crown. And looking at the root, this may be certainly viable. It's a single rooted tooth with enough length to do it, and the lateral forces on it aren't that bad. Alternatively, we could do a 3-unit bridge, extracting that tooth or actually burying the root underneath the pontic and have a 3-unit bridge on that. Not a bad idea, but really the molar only has an occlusal composite in it, and that would be sacrificing a large amount of sound tooth structure. In addition, the premolar already has some sort of build-up in it and a crown over that, and so it's a somewhat compromised tooth. The third alternative, of course, is to extract that tooth and place an implant. Here too we have two options: extract and immediately replace with an implant, or extract, do a socket retention procedure, and some 8 weeks later place an implant. In this particular situation, as you see, we have elected to go ahead, extract and replace with an implant. And we did this after evaluating all the clinical options, particularly within the clinical scenario of our day-to-day activity on that particular day. Here clinically you can see the actual compromised tooth, really fractured and not enough just to put a post and core. So we're using a periotome, passing it down the PDL, the periodontal ligament, separating it from the bone, and then removing that rather long root. We're now evaluating the socket to see there are no fenestrations on the buccal or lingual and no adjacent tooth structure passing through into it. A round burr to access the palatal wall, and then a 2mm twist drill accessing predominantly the palatal wall, keeping away from the buccal wall. And then we start on the drill specific systems, moving up to the 5mm, which is about the size we're going to utilize, in this case the blue one, which will occupy the lingual and the two interproximal walls. Now we're utilizing the tapping system or a countersink depending on the needs, and this is the 5mm fixture replace going into position with the tie unite surface. You can see the carrier already in position, and we're now driving it in utilizing the required amount of torque, placing an easy abutment on top of this, and then placing the cap on and doing a vinyl polysiloxane impression material exactly as you would do with any normal crown, of course without any need for cord. And this is the putty over the wash. Taking it out, you can see the easy abutment snap cap there, and this is the implant analog that will fit into that, so we can pour a model replicating the position of the implant within the confines of the stone model or the mouth. The soft tissue model is useful, so we do this out of vinyl, and this is the easy abutment in position, just using a polycarbonate crown, trying it on, selecting the right one, relining it, and then going ahead and placing it just with an antibiotic ointment so that we don't get any cement down that buccal interface where there might be a gap. And as we go back to the slides, in the bottom right hand corner you have the original radiograph with the compromised tooth, and then above that a digital image just one step back to where we finished checking the occlusion of placing the abutment. And I'm showing you this because you can see the actual lack of compromise to the site during the surgical procedure, the fact that we've been able to retain the first molar in its entirety, and no further compromise or extra load placed on the premolar ahead of it. And undoubtedly, when you look at the expeditious way that this has been done, with again the lack of compromise, this must be the treatment of choice for a patient in this situation. Time-wise, it was better. Financially, it probably cost less. And over the long haul, it will probably fare better, as you don't have the additional load placed on compromised teeth. You also don't have the additional problems of caries and potential root canal on the molar. Implants today, by virtue of this changing approach, certainly have become day-to-day treatments for most every patient.